Long-Term Care Committee will come to order. Members of the committee and members of the public, I always struggle with how to start these committee hearings because this is a tough subject. It's highly sensitive because people are dying from COVID-19. Our seniors are dying from COVID-19, and it's not our place, nor is it right to make a pandemic political, but I also don't want to let the facts and data to be portrayed in a way that isn't telling the whole truth. I'm so passionate about helping our Minnesota seniors that I've been dedicating time in every hearing the past 2 months to bring their voices forward to the public, including Leora's, which Senator Rood will allude to later. And this is the committee to be their voice. And if there's ever a time to hold government accountable, it is when the lives of our seniors are at stake. The main mission of this committee is how can we best protect and help our seniors. So here we are again. I feel just horrible with every email or phone call or Facebook message that I get that our seniors throughout the state have had a terrible experience with trying to sign up for the vaccine. And members, I know you've gotten them too because you've been forwarding them to me. Seniors trying to access the vaccine or having to travel many miles just to receive the vaccine. At our aging hearing, our committee members have continually questioned and challenged the governor and the Department of Health to do better, because when we continue to hear countless reports of upset seniors about their experiences and those who desperately are waiting to get the vaccine. I've been urging the governor each week for the past 2 months to listen to our concerns of our seniors and make the state's vaccine program more senior friendly and to put seniors first. I'm just going to read a couple of emails of the gazillion that I've gotten. This one's from Julia from St. Paul. I'm 62 and retired. I'm single and I live alone. I have no household to safely hang out with. I'm relatively healthy, so it appears now that I'm in much lower priority for vaccines. I have followed and accepted the governor's and MDH recommendations and guidance up until now. I thought they were doing a fairly good job, but I think they are failing at the vaccine rollout. We were told for the first time several months ago during the pandemic that age 60 and above are at high risk. So I have lived strictly according to that guideline. I wanted to be a good citizen and follow the data, but CDC changed mid-course to use 65 plus instead of 60 plus as a high-risk senior group without offering any explanation as to why 60 to 64 were no longer at risk. Given the chaos at the federal level last year, I decided to follow MDH data instead. MDH age demographic charts in their weekly reports show clearly and consistency that age group 60 to 64 has consistently either been at the highest or second highest proportion of ICU admissions due to COVID. So I considered that metric of severe disease risk for my age group. But now, according to the new vaccine rollout plan, my age group, healthy 60 to 64-year-olds, are near the end of the line for vaccines, and so many healthy young people will have access to the vaccine long before me. I do not understand and find it very hard to accept. Why can a healthy 25-year-old kindergarten teacher get a vaccine before me? Or even a friend of mine who is 69 with diabetes, heart, and kidney disease, who still cannot get a vaccine from his provider because he is under the age of 70. Or why a healthy 16-year-old food service worker at McDonald's can probably get a vaccine before me. I cannot live anymore as if I'm a high-risk group, if the state is going to treat me as if I no longer am in a high-risk group. For 1.5 weeks now, I've sent my concerns and questions and various problems to the CDC, MDH, Commissioner Malcolm, and Director Erzman. I've not received any responses or explanations to help me understand, and the political responses have just been generic template type responses. Also, I found many of the questions on the vaccine connector to be rather strange and uncomfortable. I initially signed up for it, but then I called them and asked them to remove my data because I wanted to disenroll from it. He said he would delete my data, but then a few days later, I got one of their automated email updates anyway. I unsubscribed from it, but now it appears they must have kept my data in the system, even though I specifically called and asked them to remove it. Regards, Julia in St. Paul, Senate District 67. This one is from Fran in Hoyt Lakes. Hello, I'm 61 years old and I live in a rural town up north. I have type 2 diabetes with obesity. Also, I'm bipolar with severe depression and live alone. I've been waiting patiently alone for my turn to get the vaccination. Twice the order has been changed and I've been pushed back. It is very upsetting. Please think about some of us with underlying health conditions who are seniors but not 65 years old yet. If I could get to North Dakota or one of the other wonderful states that are so generously letting Minnesotans get a shot there, I would. Thank you for your time. Hopefully you can help me and other younger seniors with underlying conditions out. Francine from Hoyt Lakes. And just one last one, even though there's a whole bunch more, but I'm not going to keep going. This is Glenn. First, my wife was selected from my wife, 68, was selected from the lottery last week, but I was not lucky. Another issue you may want to bring up is, why isn't the questionnaire asking, is there anyone in your household with the same criteria, versus some questions that have nothing to do with the vaccination? I can't imagine how difficult this is for elderly. My mom is 94, when only one person of the household is selected and they have to drive a distance. Furthermore, a site in Minneapolis is selected that is going to be near government center parking, skyways, and roads closed on upcoming days. There should be accountability on the administration for these problems that in a way they created. They had plenty of time to plan for this. Glenn. So those are just a few of them. I want to go into the stats really quickly here. I've been saying from the beginning of the vaccine rollout in December that the state needs to target our efforts towards those that are most vulnerable to die from COVID-19. I believe saving lives should be the state's only priority. In Minnesota, this happens to be those age 50 and above, and even more so over the age of 65, and those with high-risk medical conditions. So let's go through some of the numbers. There's been a total of 6,490 COVID deaths over the past year. Seniors age 65 and older have made up 89.2% of all COVID deaths. Senior and long-term care settings make up 63%, and we can't forget about the additional 26% of all COVID deaths that are seniors 65 and older living in their own homes or in their communities. 10% of the COVID deaths are those aged 50 to 64. So this makes up a staggering 98% of all Minnesota COVID deaths are age 50 and older. 2% of the deaths are everybody else under the age of 50. To put this in perspective, of the 5.35 million Minnesota residents, 485,655 total Minnesota COVID positive cases. Of the 490 deaths, 140 Minnesotans under the age of 50. 6,490 deaths, 141 have been under the age of 50. So I don't know about you, but it seems common sense to me that the state should be focusing more on the vulnerable senior population by age first instead of younger, healthier workers, no matter the industry. Because these people have an extraordinary lower chance of dying from the virus. So it's all about prioritization, and I know we've been saying that, we're beating the drum here. Due to the choices on how the state has prioritized vaccines over the past 70 days, tragically, Minnesota has lost approximately 1,520 lives, with over 1,350 of these being seniors. Even yesterday, all 4 deaths were seniors. If we could have gotten the vaccines to these seniors 2 months ago, could have we saved any of these lives? Frankly, the department and I disagree on this. Again, I believe saving lives should be the only priority and above getting vaccines to certain younger groups that are more at risk of getting COVID. I would like to hear from the Department of Health why this cannot be the only priority for the state. Each week, the department prioritizes its allocations and sends specific amounts to different providers and tells them who to vaccinate. From the beginning, seniors have been competing with other eligible groups: teachers, childcare workers, emergency personnel. In addition, thousands of state employees, prisoners, and many non-patient facing younger employees, such as accounting, IT, and HR within the healthcare systems, have gotten vaccinated. I'll go into the following concerns after we hear from the department, because I know they have limited time, but I just wanted to pull up a few slides because I believe that the 70% threshold that the governor and MDH has set is too low. We're going to be leaving some seniors that still want the vaccine behind, as you just heard from Glenn and Francine. Again, 10% of COVID deaths are the age of 50 to 64-year-olds versus 2% of those under the age of 50. Other states are revising their vaccine priorities based on science and data. We've already discussed how some states are prioritizing vaccines. West Virginia, Connecticut, Indiana are great examples of states prioritizing their seniors. AARP recommends these models, and I just want to bring to the attention 2 additional states that have made recent changes. Susie, can you pull up the PowerPoint? Maine. The state of Maine just yesterday decided to go to an age-based rollout. for vaccination eligibility. Today, effective March 3rd, the state will proceed consecutively through the age groups, oldest to youngest. The age-based approach reflects recent data indicating age is among the strongest predictors of whether a person may become seriously ill and die from COVID-19. It offers greater certainty and predictability for Maine people to know when they are eligible for the vaccination, and it's easier for vaccination providers to implement and verify. Also, operationally, it's much easier than the complex matrix that Minnesota has created. Maine has two goals for its vaccination strategy: save the lives of Maine people at greatest risk of serious illness or death, or two, ensure the vaccine providers can effectively, efficiently, and quickly vaccinate as many people as possible. And then the other state members, and this is in the packet and this is public, Arizona just did the same thing yesterday. They're moving to a hybrid age-based approach as it ramps up its rollout moving forward. The state has been vaccinating seniors 65 plus and will now prioritize those 55 and older and a small number of the frontline essential workers. And then it'll open up to 45 to 54. They felt the other convoluted way of 1A, 1B, 1C was just too confusing. So they too have gone to an age-based, what we in this committee have been recommending from the get-go. So I would like to turn it over to, it's my understanding, Commissioner Malcolm, you have limited time this morning, but I wanted to make sure that committee members have an opportunity to ask questions directly to you while we have you on Zoom. So I'm going to open up first for the senator discussion and questions for the commissioner, and then we'll turn to the slides that were prepared for the committee and were uploaded, with updated information that was released last Thursday. I'm sure most of the committee members have already seen the slides, and the new reports of this last week. So Commissioner Malcolm, I would like to open it up for questions from the committee, and I'm hoping that maybe your staff can stay on a little bit longer for this slide.
Well, good morning, Madam Chair. It's nice to see you. Good morning, members. I hope you will take slides because we wanted to share with you the impact that vaccinations are having on hospitalizations and death rates. Really good news to share. And I think it's directly responsive to what your interests are. So I hope you will do that.
Absolutely. Thank you, Commissioner Malcolm. Thanks for coming this morning. I'm sorry you don't have a lot of time. That's why I wanted to get members' questions in, and then we can go over the slides. Senator Curran, then Senator Rude.
Thank you, Madam Chair. Madam Chair, I didn't hear, based on last week's request to the Department of Health related to the fancy vaccine locator. Have any changes been made to focus it or change that application to make sure it only collects the necessary data?
Commissioner,
have any changes been made at all?
Commissioner Malcolm.
Madam Chair, Senator Curran, a number of changes are in the works. Our Minnesota IT department and health department staff are working together on that. We've given a list of requested changes to Microsoft, including moving up the age question toward the top. So that is work underway. The changes have not yet been made, but are being processed now.
Thank you. And then, Madam Chair, one follow-up.
Senator Cran.
Thank you, Madam Chair. So in there, I was reading through an article on data privacy, and it looks like many of the questions would violate our Minnesota's kind of world-renowned data privacy. We're really looked up to in relation to protecting data well beyond HIPAA, which isn't data privacy. So it looks like I was reading an article by Don Gemberling, and data expert, former state employee, and he tried to review, and it looks like most of the data we were collecting would violate our policies, in addition to when you look at the notices and notice of intent of use of data. And it looks like I think his quote is, compared to statutory requirements, the notifications and the explanation of use and data and the reason for the collection of the data is clearly deficient. Was it reviewed even based on our data privacy laws, and did that guide the development of that? And if so, how how are we going to correct it to make sure that we're clearly collecting only legal data and only data necessary that would help facilitate the vaccine distribution to the most vulnerable. So.
Commissioner Malcolm.
Madam Chair, Senator Curran, excuse me. Yes, there was a legal review before the connector was launched. At Mr. Gemberling's points, we're carefully reviewing. I think there is further legal review going underway, just to take a look at his suggestions and his questions. But definitely data privacy, clarity about what the data is used for is a completely legitimate set of questions, and we're taking those quite seriously. As I mentioned, we can bring back for the committee kind of an overview of the next iteration of the connector at another time. I do not have those details.
Thank you, Madam Chair. Thank you, Commissioner.
Thank you, Senator Curran. Senator Rude.
Thank you, Madam Chair, and thank you for Commissioner for working on making those changes. You know, it was very heartfelt last week that how disturbing those questions were to our seniors. So I'm glad to hear that you are working on them, and I look forward to seeing those changes. And so I guess my request of you today was, as soon as those changes have been made, if you could notify the committee so that we could go back into the connector and take a look at them and see, show them to our seniors so that maybe it's a better program for them. And with that, I've been asked to read Leora's letter today because she, I guess, has quite a following now of through our committee, and so I did receive this morning. So I'm just going to read it to you because I think we are in a better place than we have been. We've been really focusing on the seniors. So this is from Leora this morning. Dear Senator Rude, with great joy, I'm informing you that my 72-year-old daughter with severe COPD now has an appointment to receive the COVID vaccination this morning. And furthermore, my appointment scheduled for March 10th has been changed today at the same time as that of my daughter. Senator Rude, we are very thankful to you and Senator Housley and the members of the Aging and Long-Term Care Committee for all your work to prioritize seniors for vaccination. Without your diligent efforts, I believe my daughter and I would still be waiting for an appointment. We hardly know how to thank you. We are so appreciative. The work of your committee is so vitally important to the senior population. Although you will never know how many lives of seniors you have saved, please continue your work to get more seniors vaccinated. We feel so blessed to have you, Senator Housley, and all the committee members work on our behalf. We thank you once again for your thoughtfulness and caring, Leora. So we are making progress, and I hope we just continue to focus on getting our seniors vaccinated. I know in my own community, Riverwood Health just did a phenomenal job of vaccinating seniors. They opened up the church. They got 700 seniors. The community all brought seniors to the church. They helped them across the icy parking lots, and they really focused on getting seniors from the Garrison, McGregor, and Aiken area all together. They got 700 vaccinated, and now they've had their second shot. And so I'm pleased that we are really pushing our senior vaccinations, and I hope we continue to do that. So thank you.
Thank you. Any other members with a question? I just have one, Commissioner Malcolm, while you're still here. So again, the Minnesota data says that 98% of our deaths are age 50 and older. And we've heard from so many people that prioritizing that age group of people, Senator Abler, hang on, Senator Abler, prioritizing that group of people is where we should put our focus. And now we have states like Maine and Arizona realizing that also. Is my real question is, when distributing and the allocation of the vaccine, is it the priority to stop the infection or trying to prevent death? And if it is to prevent death, why wouldn't you start the distribution of the vaccine for those highest at risk of dying first and then work backwards? So, Commissioner Malcolm, are we at all going to ever move to this model to cover those highest at risk of death, that 98%? Commissioner Malcolm?
Madam Chair, I think we're trying to do exactly that. And as you pointed out, the great majority, 90 almost percent, are 65 and above, 60% in long-term care. That's why we started with long-term care specifically and healthcare workers. And then in the middle of January began 65 and over. We've talked a little bit in the committee, and I know the committee members have also raised the importance of getting at underlying conditions. That's why, you know, specific set of particularly high risk underlying conditions, regardless of age, is next up. And then kind of a combination of age bands and underlying conditions. So we are definitely trying to make sure that we get to the most vulnerable folks first from the perspective of severe disease, hospitalization, and death. The other priority, and I know we just, there are different points of view on this, and we, I think, have agreed to disagree, that another important role of the vaccine program is to help preserve kind of societal function and to help particularly critical sectors be able to return to as close to normal function as possible. And the in-person learning for schools, I think, is a broadly held shared goal to get as many of our kids back into school as possible. So I think, you know, the models that you mentioned about only looking at age, not underlying medical conditions, is another way to go. We've chosen to prioritize around the combination of age and medical conditions. We're making terrific progress on moving up those numbers. We're now at 54.4% of everyone over the age of 60 with at least one dose. And those numbers are increasing rather significantly daily. 70% of all the vaccines are going to that population right now. Senator Ruud's great example of, you know, the more we are able to push those doses out into the communities, to healthcare providers and local pharmacies, the faster those numbers are going to rise. So we're feeling really quite good that there's been just significant progress, even since last time we talked in the committee, at reaching that population. So, and the news continues to be good in terms of the vaccine supply beginning to ramp up so that we can move through these populations in parallel at a much faster pace. Your point earlier on, Madam Chair, about, you know, 70%, doing 70% of the 65 and above before we expand eligibility to anybody else. That doesn't mean that the seniors are not going to be a priority after we hit that 70% mark. They are still, of course, eligible. They're still going to be prioritized through all the different allocation streams. But at a certain point, you know, we're going to hit the point where we've reached the great majority of the seniors who want to get the shot right now. So we can talk at greater length another time about that. But I don't think we have any disagreement at all about the importance of reaching those who are most vulnerable to severe outcomes first. And balancing that societal function thing is where I think there's a, you know, room for different points of view.
Two things. One, on the, thank you, Commissioner Malcolm, on the societal function. Again, 98% of those that died are 50 and older. So I think you get that group vaccinated and you can get back to societal function, is my view on it. And secondly, the other states that have switched to the age-based rollout, they realized that they could capture most of those underlying medical conditions just by going backwards from age, because they had a hard time having each of the people coming in prove that they actually had these underlying conditions. So they scrapped that plan and went, you know, we're going to go basically with age back to 50 years old and over, and then open it up to everybody else. So that's where we are going to agree to disagree, I think. Senator Abler.
Well, thank you, Madam Chair. And it is just a lovely spring day outside here. Anyway, Commissioner Malcolm, I appreciate you, coming for these weeks. And, if you sense a sense of frustration from this committee, part of it's because the governor has decided to take all these decisions on his own and has included virtually none of us and even the discussions. And so then the only comment opportunity we have is to ask questions and go, hey, have you thought about this? Have you thought about that? And the states that are more successful, Commissioner, you're doing probably all you can do to include us, but The governor has not. West Virginia is number one, and they included everybody. We had a hearing about that. And anyway, so that's just the frustration you're getting from us. That we sense that, and we feel, well, kind of like we're the children, and we get like, okay, well, thanks for sharing, and we're going to go do what we're going to do. So that's just a thought. And so, ironically, so many of the IT products that Minnesota has done we've made up our own. And curiously, the one we took off the rack was one that was offensive to so many people and invades our privacy. And I don't believe it is consistent with the Minnesota data privacy laws. And Senator Coran said that really well. But I do have two questions. One is the governor said 70% is pretty good because, heck, a lot of the people are in Florida. Do you have any idea when you hit 70%, how many seniors in Minnesota will still be unvaccinated that are actually here? Do you have any idea about that?
Commissioner Malcolm.
Madam Chair, Senator Abler, we can certainly figure that number out. I don't have it off the top of my head. But again, I think it's difficult to say we are going to continue to find and offer to every senior who wants one. So it's not like we're going to say we've moved on now and 65 plus is not a priority. It's just a question of, for how long do you kind of hang on to the doses to try to find those remaining seniors versus beginning to make that available for people with underlying health conditions at a younger age, for example.
I respect that. And, I still don't know where to send people that are right me looking for a way to get one that are totally in the senior category, 70-year-olds and up. So I think Senator Housey said it pretty well. Some of those people won't need to worry because, some will be dead. So to cross them off the list. And I know I'm sounding cavalier, but we would have liked to have been included in this discussion. Anyway, just one other thing. Taken off the website now is the number of people in ICU. It must be a pretty small number that we don't even need to talk about it. But do you know how many are in ICU, like for the last week or so? And there's a way we can find out ongoing, or at least for today's number, do you know?
Commissioner Malcolm.
Madam Chair, Senator Abler, I don't believe we've taken that ICU data off the web. Maybe Chris Harrisman can comment on that.
Oh, I thought it was. So.
No, I think it's still there. I believe it's under 50 at this point.
Okay, well, that's good news.
Our rolling average, 7-day average for hospitalizations and ICU, the rolling average for hospitalizations is in the mid to high 30s, and for ICU it's less than 10. I believe it was 7 yesterday.
All right. Well, that's cool. It sounds like things are working, and and I just we're just sitting on the outside looking in, Commissioner. And I read last week, Minnesota had 6,400 some deaths. Wisconsin had 6,300. So I don't know. We just keep wondering. So I know you're working hard at this, and keep up the good work as best you can. But tell the governor we really wouldn't mind being part of the conversation. Thank you, Madam Chair.
Thank you, Senator Abler. Senator Putnam.
Thank you, Madam Chair, and thank you, Commissioner Malcolm. I actually initially lowered my hand again. Senator Abler kind of asked my question, but I'm going to ask it again, perhaps maybe in a different way. And Commissioner Malcolm, when we look at the 70% seniors goal, does that factor in any hard data? Do we have any hard data about the percentage of seniors who might be reluctant to get the vaccine or might be committed to not getting it? Do we have any idea of how many folks just don't want it for various reasons and wouldn't get it if they could?
Commissioner Malcolm.
Madam Chair, Senator Putnam, that's an important thing to understand. Where is their vaccine hesitancy, and is there anything we can do to respond to that effectively? Sometimes it's just it's not enough information. It's people wondering, well, how could these vaccines possibly have been developed so quickly and be safe and effective? So we need the scientists to speak to that. We need people's physicians to encourage them. And we need, community leaders such as yourselves to be saying, as Madam Chair has said, the way out of this is to get everybody vaccinated. We need to get to that herd immunity before we can be protected against what we absolutely expect is going to be a continuing presence of the coronavirus circulating around the globe. So getting people to take the opportunity when they have it is really important. I mean, it's a two-sided coin. We have to get the vaccine to them, get it to them in a convenient way, using this whole distribution system we have, firing on all cylinders, we've got the capacity to do 500,000 doses a week between healthcare systems, pharmacies, local public health, standing up, stand up sites where we need them. That's what we're building for and planning for, because we believe that we really are in a race against time here. And the good news is, as the vaccine supply increases, the whole goal is to get through as much of the population as fast as we possibly can, to stay ahead of what very well could be another wave coming with these variants. So we really do need to, to get as many people vaccinated as we can. So in terms of hesitancy among 65 plus in particular, I mean, that we're glad to see that that there's such demand for vaccine. Certainly in the long-term care settings, we've seen 80 to 90% of the residents in long-term care facilities eager to get the vaccine. In the community vaccination sites, I know that in some, it varies regionally a little bit. Of what we hear from our healthcare providers and local public health is that the percentages of people who are taking the vaccine offered, vary, and that there are lower percentages of people taking the opportunity in some communities. I don't know that we've got a statewide number on that. I would ask Chris Eiersman if she has anything she wants to add here. But I think that is part of that 70% threshold, if you will, is to say at that point, you probably got 90% of the seniors that want it. But that sort of was our thinking. But we have to pay attention to regional variation in that too, and work to make sure that we're getting enough allocation to those parts of the state where the uptake has been lower.
Yep, Commissioner. Yes, this is Chris Eiersman. I'll just add that yes, there is regional variation. Yesterday, when we were discussing this with our regional coalitions, they indicated that for some parts of the state, particularly some of the northern areas, there has been some saturation, and that there's been outreach and folks are not interested at this point. They did indicate that there are a number of people who have said they would really like to receive the Johnson & Johnson vaccine because of the single dose. And as we know, we got an allocation, and we don't this week, but we don't expect that to continue in the next couple of weeks. So we'll be working to make sure that that type of vaccine is made available to those populations. But there's definitely distinct regional differences in uptake.
Thank you. Follow up, Senator Putnam, or you're good? All right, thank you. All right, Senator Eakin.
Hey, thank you, Madam Chair, and thank you, Commissioner, for the work that you've been doing on this. I was happy to see in the rollout of the next phase that those with disabilities and serious illnesses are going to be included in that. And I know the governor is talking about expanding to that next phase once they reach the 70% of seniors being vaccinated. And that's expected to happen at the end of this month. I guess I have concerns related to what Senator Putnam was talking about, as far as we don't know when we're going to hit the fall off and the numbers of people who are interested in getting the vaccine. What happens if we're not reaching that 70%, by the end of the month, because there just isn't the interest there. And it sounds like, you've calculated that we should be able to reach that number before we reach the real fall off, but we don't know for sure. And so I'm a little concerned about that. And I actually feel that we should be placing those with significant disabilities, as a priority right now. And I would hate to see it put off any longer, because these people are just as vulnerable as anybody in the upper age brackets. Many of them are. And so that's my question, I guess, is what happens if you don't reach the 70%? Is that a hard, fast number, or is it something that's flexible? Is the end of the month a hard deadline, or exactly when are we going to be reaching that next phase?
Commissioner Malcolm.
Madam Chair, Senator Eakin, great questions. I think what we've said is that is a framework and a threshold that we think does make sense. But we will be watching closely to see if we start to see that the demand has largely been met. What we're hearing, just had a meeting earlier today with some of the large health systems who are working together in a consortium as are the 8 regional coalitions among the smaller and mid-sized providers. So we've got just phenomenal collaboration going on among our healthcare providers that are helping to really move the vaccine to where it's needed. We really appreciate it. What they've said is that they are watching for things like when they issue invitations to their patients, to say, okay, come on in and sign up for an appointment. How long does it take for that invitation list to get filled up? And so they can tell us and be monitoring literally day to day. What is the gap, if there is one, between demand and supply. So we'll be watching things like that. Are all the available appointments filling up quickly? And what are the providers reporting back about? They know how much demand they're not able to meet on a day-to-day basis with the current volume. So we will be looking at that number. 70% is not magic. It's not, but it's a good guidepost to be measuring against and working toward. And at the pace we're going right now, frankly, we are highly confident we're going to hit that 70% probably before the end of the month.
Great. Thank you, Commissioner.
Thank you. I have one. I know Senator Utke is on here. He has a bill coming up later. He's not on the committee, but he was in my office yesterday asking me. He's got residents in his district in Park Rapids that there are no vaccines near them, but they know if they go to the reservation, they have a surplus up there and they can get them there. Is there a reason that and I know the tribes have done an amazing job of getting all of their residents vaccinated. They're getting the federal vaccine, but the surplus there, is there any way we can get that closer to the people instead of those having to drive? And the second part of that question is the same frustration is being felt by those here in Minneapolis, St. Paul, and the suburbs. There is none here in the Twin Cities, and people are driving over an hour north, south, east, and west to get the vaccine because it's just not anywhere here. So those two parts of the question, Commissioner Malcolm.
Yes, Madam Chair. The good news is we're getting better and better, more granular data about precisely who's being vaccinated geographically and by which providers, so that we can, and we are sort of working with the coalitions to say, well, it looks like we maybe need to adjust the allocation so we get more to the places geographically that have not had as easy access, because we share that goal of getting the vaccines as close to people as possible. It was never the intent that the state sites be the main way that people are getting vaccinated. Although, just one quick point in defense of the connector, so for the seniors who've signed up on the connector, who are eligible now, anybody eligible now, principally the 65 plus, we're using that list to give to the community pharmacies and give to the providers and invite them proactively to reach out to those populations to schedule appointments. So it's it is not a passive function. When people voluntarily share that information, it enables us to get them information about where there is vaccine closer to them, and we are using it in that way. So we are definitely, I think, getting better every week with that sort of that allocation process of trying to figure out where we need to move things around to create more, to fill in some of the gaps that we know are there.
Commissioner, this is Chris.
Yes,
can I just add one thing?
Yep.
So just wanted to note that as we have seen that there are certain areas that have appeared to be more saturated, we have, for instance, asked our retail pharmacy partners to redirect their allocation. So in other words, they had allocations going to sites across the state, and we've asked them to redirect those to sites that have greater demand, as you mentioned, the metro and some of those areas, as well as we're looking at allocations for the next week to also address some of those gaps. So our goal is that everyone has access to vaccine, but we are monitoring to see where uptake has been stronger, where where an area seems more saturated, and there are changes that are being made. And as I said, we've even reached out to our retail pharmacy partners to help address it.
Thank you, Ms. Erzman and Commissioner. That's what I was going to say. I think there should be like a wider net of pharmacy partners with fewer doses, so the seniors don't have to, or anybody has to go that far. One more question, then I'll go to Senator Eakin, and I know you have to go, Commissioner Malcolm, but Senator Tomassoni, since you don't come before the Higher Ed Committee, he has a question about college instructors who have to also teach face-to-face, and he was just wondering how they're different than K-12. Dr. Osterholm seems to think that college instructors should be in front of K-12. And I know that's off our topic, but he wanted to chime in. Commissioner.
Yeah, Madam Chair, good question. Interestingly, and again, Chris Erzman might have some insight to this. At the federal level, higher ed was not called out as a separate sector, but from our point of view, at the very least, that higher ed probably should be included in the 1C group, which is an essential workforce, but not as public facing, as most those institutions are offering, distance learning options and so forth. In terms of the distinction, between E12 and higher ed, I think, to my understanding, but again, would invite Chris to comment if she has anything. It really is kind of about the distinction between the criticality of in-person learning for the younger ages versus more distance learning becoming more common for a whole variety of reasons in the higher ed models.
Yep, Commissioner, I'll just add two things. One is that yes, when this was first discussed by the Advisory Committee on Immunization Practices, they were looking at some of the National Academy's recommendations. As you know, it was that joint framework looking at these issues, and the National Academies had really focused on childcare in E12. So the K through 12 or early childhood through 12. Part of the reason for that is, as we've talked about, the societal functioning, but also the fact that younger ages have greater difficulty in being able to follow social distancing, masking, all of those things compared to college students. Additionally, as the commissioner said, in-person learning was, deemed to be really critical for those ages, whereas, in the higher ed setting, you're working with adults who can follow guidance better, and in many cases, there are opportunities for online learning, but social distancing is much easier in those settings. Over.
Thank you. Again, I'm just going to say it here. 98% of those who have lost their life to COVID are over the age of 50, and only 141 of the 6,950 deaths have been under 50. So again, I'm going to plead to keep focusing on our seniors and those 50 and older and getting the vaccines to them. That's my mission, and you guys know it. So I just wanted to make sure I said that in all of that. So with that, we can go to your slides. I know we all have them, but that would be that. Thank you for taking our questions earlier, Commissioner Malcolm.
Madam Chair, thank you. My apologies. I do need to leave, but there's some very good news in the slides. So I hope happy to come back and talk about what we're seeing in terms of the impact. Thank you. Talk to you soon.
You. All right. Bye-bye.
Bye-bye.
I think it's probably you, Dr. Erzman, who's going to be doing the slides.
I'm just checking to see if my colleagues are.
Yep. She's got it.
Okay.
Lisa's got it.
I will start.
Okay, great. Thank you.
So I will say, Chair Housley, this is Lisa Timian, and I think we did. This department was only available until 9 a.m. this morning, so we're already overscheduled. We're missing some other meetings that I know Chris Erzman is supposed to be at. Dan Kitzberger and I can stay on to present the slides, but we are missing some other stuff that we're supposed to be doing this morning.
Thank you, Ms. Timian. That's fine if you and Dan want to stay on. Audio is a little, it's echoing.
Dan, do you want to walk through these or do you want me to?
I can. Can everybody hear me okay?
Yep, you guys are both good now. Thanks.
Okay. So we'll just provide a brief operations update. As many of you may have heard, the Johnson & Johnson or Janssen, which is their pharmaceutical division who developed the vaccine, has been approved by for emergency use authorization, and we've placed an order, and those will begin arriving in the state this week, and we'll begin administering those this coming weekend. The past several days, we've administered over 270,000 doses throughout the state after those severe weather delays a couple of weeks ago at the end of the week. And at the end of last week, we actually set daily records for doses administered on both Thursday and Friday as a part of catch up for those delays. So that is, part of the good news. I think we've indicated before that, our vaccinator network that we've built out around the state has the ability to administer over 400,000 shots a week. We still only get about 140,000 into the state per week to be able to get out into Minnesotans' arms. So as we continue to ramp up supply, we'll be ready for it. And then as we briefly touched on, we've released more detailed guidance into phase 1B and C and phase 2. Next slide, Lisa. So I wanted to update on the national rankings. I know it was mentioned earlier that West Virginia is number one. They do, remain near the top, and there's a lot of fluctuation week to week in these rankings. Minnesota ranks third currently in the percentage of vaccines administered of the doses that have been delivered to the state. You can see that West Virginia, as of yesterday, ranked number 10th, along with, some of our neighboring states are in the top 10 as well, which is great, great news because, we work together along the borders to make sure that we're controlling the spread. Next slide, Lisa. So just wanted to share some of the good news that's coming out of the progress in long-term care settings. Go ahead to the next slide, Lisa. So we continue to be kind of in this trough in terms of resident cases and staff cases for that matter in long-term care settings. That's in large part due to the very good work these settings have done in helping control the spread and mitigation measures put in place, but it's also attributable to the vaccine efforts. As we've indicated before, we're on track to provide second offerings by the end of this month, and in all long-term care settings, we'll make subsequent passes in those settings just to make sure that all staff who've wanted it are getting it. We've indicated previously that some staff are choosing to wait, and so we'll make subsequent passes to make sure that staff are getting their second doses as well. You can go ahead to the next slide, Lisa. And this just shows that trough continuing for both staff and residents alike. Next slide. Wanted to show some of the other metrics in long-term care settings. So this is, we have the decrease in cases, which is pretty significant and fortunately remaining low from the peak, late in the last fall and early winter. So this is the decrease in cases overall. And if you go to the next slide, Lisa, also looking at a similar trajectory in hospitalizations for those in long-term care settings week to week, and that continues to remain low as well, in large part due to the rate of uptake and vaccination in those settings. Next slide, Lisa. And then here we see the decrease in deaths, and it's been a really significant and notable and fortunately a steady decline over the past several weeks and several months since the peak in last fall. Next slide, Lisa. So as a result of that, we are able to be in a place where about 96% of facilities in the state must allow visitors. So as you know, that facilities choose whether to use the CMS or MDH guidance data, the CMS or MDH data to determine test positivity rates, which helps establish those visitation guidelines. So we've got 4 counties in Minnesota right now that are above the 14-day 10% test positivity from CMS, and then 3 of those based on MDH data. So they could restrict visitation to just compassionate care and essential caregiver visits. So 96% of those can allow visitors, and they must do so based on this guidance. And so, you know, we are hearing, you know, anecdotes, and there's been some news coverage about how there is some normalcy returning to long-term care settings, you know, of course, with some measures, safety measures still in place in order to make sure that transmission remains low and manageable. So those are good news. That's good news. We're cautiously optimistic about that continuing, and we're very grateful for the continued good work of our long-term care partners. Next slide, Lisa. So just wanted to show again some of the trends that we've been sharing the last couple of weeks. This graph shows, you know, since we started vaccinating, the trajectory and cumulative percentages of Minnesotans vaccinated who've gotten at least 1 dose. And you can see the trend lines are very stark, particularly for those 65 plus. That sort of green colored line is the third one from the top, or I'm sorry, the second one from the top is 65 to 74, and that top line is 75 plus. And again, about 67% of the share of first doses administered last week, which is the last complete week we have data for, 67% of those went to people 65 plus. Next slide, Lisa. And here we've got progress as of yesterday. We're looking at approaching a quarter of Minnesotans 65 plus who've received the complete series. You know, we'll obviously have to change and kind of update some of the way we're doing counting once the Johnson & Johnson vaccine is online, since that's a single dose. And, you know, we've heard a lot of interest in that one from a number of different communities around the state. And then we're looking at cumulative 466,000 Minnesotans with at least 1 dose, or who are 65 plus. Next slide, Lisa. So as I mentioned, just a little bit more about the emergency use authorization of the Johnson & Johnson vaccine. So you may be aware that the Operation Warp Speed, as part of that process, we sort of stacked the traditional approval processes on top of one another. So it's really important just to note that none of those processes in part of the clinical trials or you know, the manufacturing processes were skipped. They were stacked on top of each other. We began production of these, not quite at scale, but we began production at the same time they were being put through their clinical trials. So this is a 1-dose vaccine that has been found to be safe and highly effective at preventing severe illness and 100% effective at preventing death in persons 18 and older. And again, the fact that it's a 1-dose vaccine, we think this is really a game changer. And we look very much forward to getting that out and being part of our vaccine mix. Next slide. So I wanted to just point out the new measure we have on our dashboard, since we have put that 70% threshold out there. That one will open up to the next phase. So we added a metric for people who are 65 plus and have received at least 1 dose. Next slide, Lisa. And then here again are our allocations for this week for the orders placed last week. I don't know at this point. I would have to defer to others who've already left the call. If this includes the Johnson & Johnson order, that's on a little bit different timeline. We just placed orders for that on Monday. These are orders we would have placed last Thursday, and so are available for this week. And the percentage breakdown between our vaccinator types is on the right side there. I know we've talked a little bit about being able to sort of drill down by provider and how many doses they're getting. With the change in an allocation process and moving that process to the coalitions, we're still working on establishing some kind of more routine and clarified lines of communication of when they report back to us. So, we provide an allocation for what we call the care delivery system. So those are the larger providers, and then they distribute out among their locations. And then we provide an allocation for each healthcare coalition in the state that distributes to small and mid-sized providers. And so we're just working with them without having to communicate with each of them individually to be able to report back to us about how doses are being distributed among their locations. Next slide, Lisa. If there's time, we can kind of briefly go through the next. Lisa, why don't we fast forward to the graphic at the end? So some of you may have seen this. We put this out on our COVID website. This is what we're looking at as far as next phases. And so once we hit that 70% threshold, we open up. Of course, very important to note that people 65 plus, those who are currently eligible, remain eligible. Their window does not close. And so we'll open up to a handful of very specific conditions that we know lead to increased severity for COVID outcomes up to and including death. And along with that, some targeted essential workers, such as those in food processing plants, given the importance of that industry to not only the state, but to be able to feed the country and the world. And then we're including people with rare conditions and disabilities that put them at higher risk. And we've asked that providers use discretion in these situations. So if a provider feels that their patient is at an increased risk because of a condition they have or a disability they're living with, that they be prioritized for a vaccine. And then beyond that, we start to lower in age and then overlap with conditions that the CDC has identified. We included, I should note, we included type 1 and type 2 diabetes. I know folks have heard a lot about that from their constituents. And so wanted to make sure that those folks were included as well. And I think that's it.
Thank you, Mr. Kitzberger. I really appreciate that. Members, are there any questions? I have one. Either Mr. Kitzberger or Ms. Timian. When we get those Johnson & Johnson vaccines, and I do agree it's a game changer because the one shot is going to be so much easier for our seniors. Will you be prioritizing those for seniors?
Madam Chair and members, I don't have a lot of insight into that process. Again, we'll be prioritizing based on the guidance we've already put out. We have been working with our vaccinator partners, the systems along with pharmacies. Early on here, I will say that we're going to see a fairly sizable allocation of the Johnson & Johnson vaccine. I think we're looking at about 45,000 doses in this first order. Beyond that, we don't have a lot of predictability. So what we asked early on, we kind of put out a call of, who do you think who has interest in these, both in terms of our vaccinators of being able to meet our timeliness metrics, so the 72-hour goal and the 7-day goal, and then who do we think has patient populations that would be interested in this vaccine. And so we did get a pretty good response. As far as I'm told, I don't know specifically, kind of who raised their hand, but I would imagine that 65 plus will be a pretty good portion of those who are going to be vaccinated with this particular vaccine.
Thank you, Mr. Kitzberger. One more question. So these new these next stage workers that will be coming in after we get to the 70% of seniors that want to be vaccinated. What is that population number? Because I'm just wondering, that's the number of people that are actually going to be competing with seniors for the state number of shots. Do you know what that number is?
Yeah, the projections I've seen, so for that next phase overall, that includes people living with those handful of conditions that we know put people at elevated risk for severe outcomes, those food processing workers, and then the people with rare conditions. The last projection I saw was about 80,000 people statewide. And so I think what we're looking at is a convergence of a tapering off of the 65 plus population and, having to shift to more of a sort of an outreach approach, hence the need for the connector, right? And having to start to actually find people who are interested in the vaccine in addition to them still trickling into their providers, along with a ramp up of supply. And then that ramp up of supply being able to meet that demand from the continued demand from the 65 plus population, and then the demand from the workers and those who are eligible as part of that new phase. And I think the overarching goal here is that we don't slow down in terms of our pace of vaccination. We're at close to 40. Oh, go ahead, Lisa.
Oh, sorry.
Ms.
Yeah, Madam Chair, members of the committee, I think a useful analogy that we've been using on this is there's been this vaccination highway that we've been on that's been going 65 miles an hour for the last few months. And we're merging in new lanes of availability, right? So people are still we're getting up to speed and we're not slowing down. We're just continuing to press ahead, but adding more folks into these categories, which at least for me has been a useful way of thinking about it.
Thank you, Ms. Timian. Members, any questions? Seeing none, I thank you so much for coming, Ms. Timian and Mr. Kitzberger, and presenting those slides. I just want to reiterate again to prioritize those 50 and older, and also the public deserves full transparency on how the governor, like Senator Abler said, it's been really, really hard to be left out of these decisions, which is why I keep dragging you guys back here every Wednesday morning. It's been hard to be left out of these discussions. And so this is our only way for the public's voice to be heard. But I also, on the flip side of that, the public deserves transparency on how the governor is making these decisions. So again, in this next phase, I disagree with the governor that some seniors 50 to 64 are going to have to wait until May or June to get their vaccine because we are merging all of these other lanes and further diluting the vaccine distribution. So that's me and my soapbox. I believe that seniors should be in the HOV lane and have exclusive access to that highway until everyone over the age of 50 that wants the vaccine should get it. So thank you guys again for coming. Next week, I think we're going to talk about how we're going to have you back to discuss reopening procedures for long-term care settings. So thank you guys so much, and we will talk to you soon.
Thank you, Madam Chair.
Thank you. Next up, Senator Utke, you've been patiently waiting and to hear your bill. Every week you get to hear your bill at the end of our vaccines discussions. But members, we do have a quorum. So Senator Utke, Utke, you have Senate File 1482. Senator Rude, would you like to move the bill? Senator Rude moves Senate File 1482. Senator Utke, please present your bill.
Thank you, Madam Chair. And actually, tuning in early to your committee hearings is an interesting process, so I have enjoyed it. Lots of good information, so thank you. But members, today we've got Senate File 1482. This affordable assisted living bill would increase the rate for 24-hour customized living under the elderly waiver, which is an alternative to nursing home care. Affordable assisted living uses low-income housing tax credits to finance the building, and Medicaid elderly waiver reimbursements through the Department of Human Services to fund the needed assisted living services like a 24-hour customized living. Currently, SCA Properties has developed the only known affordable assisted living facilities in Minnesota, and they have 3 facilities located Brooklyn Park, West St. Paul, and St. Cloud presently. The problem is that 24-hour customized living rates are too low for SCA Properties to meet their costs. Because of these low rates, there is no incentive for anyone else to build and run these critical facilities. You do not need to take my word for it, just ask DHS. In 2019, DHS issued a report stating that these 24-hour customized living rates were insufficient for providers to cover their costs. Currently, most assisted living communities in Minnesota limit the number of units available to Medicaid participants. CSA, the National Development Council, and Affordable Housing Partners have invested $105 million in Minnesota to provide over 450 low to middle income older Minnesotans access to assisted living apartments with modern, secure, and comfortable housing with services included. Further development is on hold pending improvements in the payment system. The current elderly waiver program is complex and difficult to navigate for providers due to multiple case managers at managed care organizations in counties and tribes. The program creates assessment and rate conflicts and is unpredictable with both service plans and rates. Inconsistent application of existing rules and guidelines between health plans and counties leads to a wide variation in outcomes. The bill before us contains 3 sections. Section 1 requires the DHS commissioner to revise the customized living tool to incorporate the rate increase. Section 2 makes the rate increase applicable to managed care. Section 3 is the heart of the bill. It defines eligibility for the rate increase by establishing a rate floor equal to $119 for 24-hour customized living. Section 3 also states that the bill is effective July 1, 2021, or upon federal approval, whichever is later. And members, one last comment on the bill. The heart of the bill is the creation of statute 256S.205. This new language deals with the rate adjustment. For a facility to qualify for this adjusted rate that we're talking about here today, they must have a census of at least 80% elderly waiver participants on May 1st of the application year. So this is a bill just, again, for those places that have over 80% Medicaid pay residents. So with that, Madam Chair, we have with us this morning former Minnesota Department of Human Services Assistant Commissioner Lauren Coleman to talk more about the bill.
Thank you, Senator Utke, and hello, and good to see you again, Mr. Coleman. Welcome back to state government. Thanks so much for coming.
Good morning, Madam Chair and members of the committee. As indicated, I'm Lauren Coleman. I'm working with SCA Properties, who has developed the 3 affordable assisted living communities in Minnesota. And previous to this, I was at the Department of Human Services as an assistant commissioner for 15 years Didn't seem that long when I was there, but it was 15 years. I'm here simply to request a rate increase under the 24-hour customized living elderly waiver, which, as indicated, is the alternative to institutional care in a nursing home. Minnesota's always enjoyed a national reputation as a leader in long-term care and supports for older Minnesotans, but you can never relax. Demonstrating that elderly waiver residents can live in a modern assisted living community with private apartments and amenities would once again add to Minnesota's reputation as a leader for others to follow. The alternative default is for these older Minnesotans to be placed into nursing facilities at more than $100 plus per day additionally. We've developed these three affordable assisted living communities, as indicate Brooklyn Center, West St. Paul, St. Cloud. They are the only known affordable assisted living communities that were built expressly for low to moderate income older adults, serving 80 to 95% Medicaid participants. As indicated, most assisted living communities have to limit the number of units available for Medicaid, but each sanctuary community welcomes Medicaid participants day one and will not ask someone to move because they've exhausted their assets. Why is the legislation needed? Well, they've done whatever they can do to try to improve the results. SCA Properties contracted with Ebenezer Senior Management Services to manage all three communities since March 1, 2019. This Minnesota-based organization brings extensive senior living experience to the projects and has demonstrated success at delivering quality care to Minnesota older adults. The customized living rates are insufficient to meet a provider's cost of providing the needed services. So each sanctuary community is currently losing at least $1.5 million per year and does not see an improvement in that under the elderly waiver system. In closing, while I was at DHS working on senior issues, I always wanted to provide services in keeping with a person's individual wishes, regardless of location, economic status, or ethnicity within our available resources. If someone wanted to stay in their home, we brought services to them. If someone wanted to live in a senior community, we helped them find a suitable one. Delaying skilled nursing home care as long as possible if those more expensive services were not necessary. Minnesota has long been a model for that approach nationally through rebalancing. This is what attracted me to this project following retirement from public service and why I continue to be involved. I ask for your support. Thank you for the opportunity to testify. I'm happy to answer any questions you may have.
Thank you, Mr. Coleman. You got a good gig there in retirement. You should be proud. That is a good cause and I'm sure you're passionate about it too, I can tell. So thank you for doing, I'm glad you retired so you could go do this work. Senator Hoffman, question.
Thank you, Madam Chair. And I see Senator Abler has his hand up as well. And maybe this is a question for all of us. We've brought this bill a few times. And I guess, Lauren, first of all, I want you to get into the weeds on rate methodology and DWRS. So just you could refresh Jim Abler and Kent Eakin about all the work we've done all these years. But I'm kidding. Aside from that pathway of doing this is an important bill, but there isn't a House companion. What's your view? How do you see this moving in the House? How are we going to pull it in through Senator Abler's committee, et cetera? And maybe Jim can respond to that as well, Lauren. So I like what you're doing here, and I always have.
Thanks, Senator Hoffman. Mr. Coleman.
Madam Chair, Senator Hoffman, thank you for reminding me of DWRS.
No.
And all the all the pleasure of developing that. We do hope to introduce this in the House of Representatives also. And as far as the process, that's more left up to the Senate and the House as to how this will get merged. We hope to have an opportunity to present this additionally. It is important work, and it is raising some issues that need to be raised. We have been working on this for a while and talking with other legislators. The hope is that the legislature will support this request, and we will be able to continue to provide affordable assisted living to approximately 450 Medicaid participants.
Thank you, Mr. Coleman's follow-up, Mr. Hoffman's follow-up, Hoffman.
No, I good up. Yeah, ladies and gentlemen, Senator Jim Abler. Thank you very much.
Senator Abler.
Yeah, now we're just calling him Hoffman. Thanks, Madam. There's no Mr. going on there, Madam Chair. Anyway, so I want to just put in a plug for the merits of the bill. The challenge is paying for this, of course. I think it's like in the range of $5 million or something, but it's $5 million well spent. The problem, Madam Chair, we've been so distracted by COVID, we haven't talked about living arrangements for seniors. But I would just tell you that a lot of places, for whatever reasons, I won't question their motives, but I do sometimes question their motives for the low percentage they take of seniors on elderly waiver. This is the every person opportunity to live respectfully in a place that can support some of their needs while not having to go to a nursing home. If you haven't got family and you're eligible for elderly waiver and you cannot get into a slot, you'll be in a nursing home, Madam Chair. And that's not what nothing of the dream. They don't want to die of COVID. They don't want to die alone in their nursing homes. And they don't want to just be living, horribly. And so I want to commend the people behind this bill that have spent $1.5 million a place. I think that the members in the public may realize you can't keep sending $1.5 million per unit per building and have it continue. And they've sunk a ton of money in here. I don't think for profiteering motives. I think in a real earnest effort to serve. And so I have tried every way to Sunday to try to find a way to increase the accessibility of this service and actually require more of the other companies to upscale their percentage of elderly waiver. And we've had some hearings about that, Madam Chair, and it was always a rather interesting discussion, shall we say. But I want to commend this company and the other companies that are serving high percentages of elderly waiver that are not subject to this bill, or they may well be, I don't know, but it's really important. And I would just love to find a way to get the money to reinforce quality housing for these very important members of our community. So thank you, Madam Chair, and thank you to everybody.
Thank you, Abler. Kidding. Thank you, Senator Abler. Members, are there any further questions or any further discussion? Seeing none, Senator Utke, I love this bill. Thank you, Mr. Coleman, for coming. And I hope, I will be seeing you in the next committee, I'm sure. But Senator Utke, did you have any final comments?
Yeah, I actually did want to add one thing before you go to the motion again. But and that was, we haven't brought up the fact that 70% of their overall cost is labor in these facilities, like a lot of them are. But some of their labor pool is basically the same pool of people that a lot of the other providers that we have authorized increases for over the last few years and such come from. And so that is part of their problem too. And that's why they're here with this, is the fact that that pool of labor that works in they're there, they serve, they enjoy what they do. But, if you have to choose one of these places over provider X down the street that works in a little different environment that has a higher pay rate, that's what's creating a big part of this problem for them. They're having to be competitive labor-wise, and that's creating the $1.5 million a year shortfall. So I just wanted to add that before we wrap things up. But with that, Madam Chair, thank you for hearing the bill. And I think it's got a lot of wonderful merit. We just have to figure out where the money comes from and how we can help them out.
Thank you so much, Senator Utke. Senator Abler, you need to mute. Senator Rude moves Senate File 1482 to be recommended to pass and referred to the Human Services Reform Finance and Policy Committee. Members, make sure you are unmute. Oh, no. Now, Abler, you can unmute.
I'm just so confused, Madam Chair. Mute, unmute. We can't hear you. You're muted. Oh, sorry.
Okay, members, we're going to vote on Senate File 1482. All those in favor say aye.
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 All those opposed, no. The motion prevails. All right. Guys, I absolutely love this committee more than anything I do in my day-to-day life. This is so fulfilling. Thank you again, Mr. Coleman. Thank you, Senator Utke. Thank you to all of those out there watching. This committee has gotten a huge following. I want to encourage any other senators or anybody, if you want any questions asked of MDH or anything that has to do with seniors, to contact us, email us, and we will gladly ask the department, whoever is before us, because I know it's tough to get communication to the governor these days. So with that, guys, the Aging and Long-Term Care Committee will meet next Wednesday, March 10th at 8:30 over Zoom. Thank you very much, and we're adjourned. Bye.